we know that relapse can happen. Dr. Ghobrial, how common is relapsed or refractory disease?
Yeah, unfortunately, we do have amazing remissions. We have very long remissions. Many people are living 10 years, 15 years and longer, which, as Dr. Nadim said, was not something we knew about years ago. I trained 20 years ago as a fellow, and myeloma was, a survival of 3 to 5 years. We've come a long way, but we want to change that even better. We want cure. We want to tell a patient, you're done, you're cured, and we will not stop until that happens. So when people have a progression again or relapse, then we want to consider what's the next available option. What is the best option to give them yet one more long remission? We are failing sometimes, and that's because the disease is so bad, the biology of the disease is so bad, and the drugs that we're using may not be the best drugs for that patient. And that's why we need to understand better the biology and pick the right drugs for the right patient upfront as much as we can. And also think about earlier treatment. We were just saying we probably have amazing drugs, but we're waiting way too long until people have almost metastatic disease and then we treat them. Why not think of an earlier interception when the disease is less mutated, when you have less cancer cells, a better immune system, and use your best drugs then, and hopefully we will achieve cure in many of those patients.
Mm-hmm. What testing takes place after a relapse? Is it different than what has happened before, the testing that was done before?
No, the same test exactly. We sort of say it's restaging. We check everything again, the bone marrow biopsy, the FISH, because you may now develop a 17P that was probably there, but a very, very small number of cells that you cannot detect, and now it grows because of something called clonal selection. The drugs kill the sensitive cells, but they don't kill the bad cells. And that's how we can get all of those changes and mutations.
Okay. Dr. O'Donnell, is the process for choosing treatment different for a relapsed or refractory patient?
Yeah, so that's a great question. Yes, it can be. I mean, again, it always depends on, how the person is doing at that time. It also depends, there are certain drugs that may not be approved in the frontline setting, like venetoclax. If a person has a specific translocation, this 1114, that's something that we would look at in the second line setting, for example. Usually one of the big questions that people ask is if you're on a specific class of drugs, should you change classes? So this example is if you're on Revlimid maintenance and you have evidence that your disease is progressing, should you change to a different type of drug, a proteasome inhibitor, a monoclonal antibody? Should that include one of the same class of drug like pomalidomide, which is the next generation? So there are a lot of different factors that we consider, the number of drugs. So, as Dr. Nadim said, historically, there's a lot of history in myeloma therapy, and it's been an evolution. And so now, we've had people who were treated with a 3-drug combination that are starting after many years to progress. So we might choose a monoclonal antibody for those patients because it wasn't available at the time they were diagnosed, versus patients now who are typically on 4-drug regimen that include those monoclonal antibodies and all the different classes of drugs. We're looking at different and if available, novel agents to put those patients on. And again, I think Dr. Nadim made a really important point that I want to underscore, which is that very often our best therapies are available in clinical trials. And so when and if there is the opportunity to be on a clinical trial, you may be then able to get something that would not otherwise be available to you. So I encourage people to always have an open mind to being on a clinical trial at any stage in their disease treatment.
Mm-hmm. What therapies are available for relapsed or refractory disease? Are they different than other therapies?
So that's a great question. So yes and no. I highlighted one example that might be a little bit different, but in general, we're very fortunate that we have multiple classes of drugs, meaning we have different drugs that work differently to kill your myeloma cells. And as Dr. Nadim said earlier, we use those in combinations to increase the effectiveness of those medicines. Within each class, we have a variety of drugs. He used the example of immunomodulators and showed that we have 3 different of those type of drugs. We have 2 different proteasome inhibitors. Beyond that, we have other classes of drugs that were mentioned. We have monoclonal antibodies, immunotherapies, and so very often we make it's almost like a mix where we pick what we think is going to be most effective. Sometimes based on cytogenetics, the biology. Sometimes based on patient selection, what are their other medical problems, what are their current issues, and we pick the combination that we feel is going to be most effective from the different classes of drugs that we have together, usually trying to use multiple drugs in combination.
Mm-hmm. Well, what newer therapies are available or in development for refractory and relapse disease?
So I think that, the greatest interest that I think we're all most excited about is the immunotherapy space. And I think we've seen, for myeloma, we see that this is the relapsing and remitting disease. And what's been so exciting about CAR T cells and the bispecific antibodies is that in patients who've had on average 5 relapses, we're seeing tremendous results. So complete remissions or very good partial remissions that last. In fact, can last up to 2 years on average with one of our CAR T cell products. So this is really exciting, especially when you compare to what historically has been out there for patients who've had that many relapses. And just as Dr. Nadim said, the way that drugs enter, they enter from the relapse refractory setting. Ethically, that's what makes the most sense, and they march their way forward. And so, that process is happening right now as we speak. And I think what Dr. Ghobrial talked about is the importance in early disease of thinking about using these really exciting therapies in patients who have lower burdens of disease with a goal of cure. And so I think all of us on this call are committed to one thing, and that is curing multiple myeloma and even the precursors that lead up to it, so that patients never have to go through the process of years and years of therapy. And so I think we're very excited about what immunotherapy might be able to offer as we move it forward in myeloma treatment.